Checking his pulse.
Oh, there we go. There's some cameras. Okay.
I still can't see any.
Yeah.
Kevin and Rhonda are on. That's who I want to see on a Friday afternoon. Kevin and Rhonda.
On Friday the 13th, especially.
Yeah. I think we should just go ahead and get started, Sam.
Okay, great. Welcome everyone to the PTW team. And at this point in time, I'd like to go around the room if we can introduce ourselves and also what organization that we are from, please.
Chelsea, do you want to do the roll call for us?
Yeah, that would be great.
I would be happy to. Just starting from the top of the list, from what I see, there's myself, Chelsea. I'm the administrative assistant with Greater Columbia. I see Diane Halo.
This is Diane Halo, and I'm project manager from Greater Columbia.
I see someone signed in as Greater Columbia. I'm wondering if that's...
Hi, this is Brisa. I don't know why it's showing up like that on my end, but hi everyone. My name's Brisa Perez. I'm the new Community and Tribal Engagement Specialist with Greater Columbia ACH.
Thanks, Brisa. No worries, we can fix that later. I see we have Sam with us.
Yes, Sam Riddell, and with Greater Columbia. No.
Wes Lucky.
Good afternoon, everybody.
Barbara Mead.
Hello, Barbara Mead with Lourdes.
We have Molly Calhoun. Maybe she's on mute. We have Carol.
Good afternoon. Thank you for joining all of us for the Practice Transformation Work Group meeting.
We have Dan.
Yes, good afternoon. Dan Ferguson with the Allied Health Center of Excellence, representing the community college system and representing workforce on the board.
Kevin Martin.
Kevin Martin with Kittitas Valley Healthcare.
Lindsay Noble.
And Lindsay Noble with Consistent Care Services.
Berta Lopez.
Hi there, Berta Lopez with Virginia Mason Memorial.
Mark Wakai.
Yeah, good afternoon. Mark Wakai, Providence St. Joseph Health in Cadillac.
Misty Queen.
Good morning, or good afternoon, Misty Queen with Molina Healthcare.
Rhonda Hoff.
Hi, Rhonda Hoff, Yakima Neighborhood Health Services.
And Victoria Urbina. No, she might be on mute.
Hi, this is Victoria. I'm with Tri-Cities Community Health.
Looks like we just had Elizabeth Rice join us.
Yes, I just joined. I apologize for being late.
No worries, we're just doing introductions. So you came right on time. Is there anybody I did not call?
Yes, I'm here, Chelsea. This is Lauren Noble with Greater Columbia ACH.
Oh, Lauren, I'm sorry I skipped you.
And this is Molly with Cadillac. I apologize. I'm having some tech difficulties with my headset here.
Thank you, Chelsea. At this time, I'll go ahead and turn it over to Mark Wakai.
Yeah, good afternoon, everyone, and welcome to the Practice Transformation Work Group call, and special welcome to our couple of new members. Thanks for putting out all the information ahead of time. It's a lot of information and it's a packed agenda, but we certainly appreciate you coming or joining on a Friday afternoon. So looking forward to the conversation. Sam, do you have anything prior to going to the minutes?
I do not at this point in time. Thank you. Just mine is added into the agenda.
Well, everyone, if we could please take a look at the message sent to us, and so we can review and the minutes of August, and then after review, entertain a motion to approve.
I think we're all speed reading, Mark.
Yeah, I'm waiting. I'm waiting. Yeah, thank you.
Well, the minutes accurately reflect that I wasn't there, so I can't make the motion.
Okay, thank you, Kevin.
This is Rhonda. I'll make the motion to approve.
Thank you, Ron. There's a motion to approve the minutes. Is there a second?
I'll second it. This is Dan Ferguson.
Thank you, Dan. Any further questions or comments? All in favor of approving the minutes, please say aye.
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 Any opposed, same sign. Minutes approved as written. Thank you, everyone. Wes, it looks like maybe you're up for the baseline on our P for P.
Hello, everybody. Chelsea, can you put up the presentation, please? Thank you very much. So we sent out a copy of this, I think, earlier today, which was updated just a little while ago. We added a slider to it. What we're going to talk about today are pay for performance measures and the high performance pool. These are two areas in which the ACH, actually all ACHs, can be paid through the District Medicaid Transformation Project. Let's go to the next slide. There we go. So I just wanted to list here some of the sources that go into this. The primary source here used is the Delivery System Reform Incentive Payment Measurement Guide. If you're suffering from COVID insomnia, this makes a great remedy. It's about 125 pages. It provides quite a bit of detail about how the scoring is done for both value-based payment incentives, pay for reporting and pay for performance incentives, the high performance pool, and more. It doesn't give away all the information about how scoring is done, but it does provide us a lot of detail about what Healthcare Authority and the independent assessor is using to score the transformation work. We can go on to the next slide, please. So this framework comes out of the guide, and it's been used in some of the presentations that have been given by Healthcare Authority. There's a lot of boxes here. You'll see those covered in blue that say project incentives. So the ACHs get paid in a number of different ways. We get paid through integrated managed care. We get paid through VBP incentives, but most of our money comes through project incentives. And those project incentives are divided across pay for reporting and pay for performance. And much of our project work up until this point in time has come through pay for reporting, and this mainly comes through the semi-annual reports, which the next one is due at the end of January. However, going forward, more and more of project incentives will be coming through pay for performance. Now, a lot of this work rolls up to what's called statewide accountability, and this is how the state of Washington gets paid to fund this program. We're not going to go into detail about that, but I'll tell you that there's three main ways that the state gets paid. The first way is through integration, which is now complete across all ACHs. The second way is through value-based performance, and the third way is through quality improvement. in the future, we may do a little more of a deep dive into how the state gets paid because it's informative to our work. And the next slide, please. This is something that we've presented earlier, and it just shows, again, DY2 is for 2018, DY3 is 2019, and DY4 is this year, 2020. As we can see, as we proceed along through the MTP, more and more incentives come through pay for performance. Even though we're in DY4, which is 2020 again, we are being assessed now for 2019, of which 25% of our incentive payments will be held to pay for performance. And let's go to the next slide. So this is something that we've seen quite a bit. We've reviewed quite a few times. We call this the Christmas tree. We're not going to go into too much detail here, but it's important to point out that each of the 4 project areas has pay for performance metrics tied to it. Some of them, some of the projects all tie to the same metrics, which include inpatient hospital utilization and outpatient emergency department visits. So in the scoring, those particular metrics are counted 4 times. And we'll look at some analysis here in just a little bit. But it's just important to know the broad range of metrics that are included in the transformation. Some of these metrics are singular, such as diabetes eye exams and diabetes hemoglobin A1C testing. Some of the measures actually have sub-metrics, such as child and adolescent access to primary care. That particular metric is broken down into age bands. And again, that becomes important when we get into the scoring. Let's go on to the next slide. So just a little bit of detail, hopefully not too much detail here, but to talk about some of the information that's in the background for the measurement process. The state of Washington is responsible for the production of the pay for performance metrics. The ACHs themselves are not accountable for collecting performance metrics. However, we do hold our organizations responsible for identifying clinical quality metrics and measuring those. But that particular work does not feed into the incentive scoring and payment process. The data sources that are used for this include Provider One. This is the biggest data source. The management information system that collects Medicaid claims provides most of the information that ties into the pay for performance metrics. Vital statistics around death and birth, the First Steps database, Washington State Identification System for arrests, and the ACEs data system also feed into a smaller group of the pay for performance metrics. So the eligible population, as we all know, is Medicaid and Children's Health Insurance Plan beneficiaries, CHIP beneficiaries. So for the most part, we are looking at the behavior and the activity of Medicaid beneficiaries who have comprehensive physical and behavioral health care benefits. This excludes beneficiaries that are duly eligible in both Medicare and Medicaid, simply because getting the Medicare information is a little bit harder to do. However, duals fit into the high performance pool, which we'll go to in just a minute, or in just a few minutes. Also excluded are beneficiaries with primary insurance coverage other than Medicaid. This includes third-party liability. It also includes individuals who might be receiving employer-sponsored insurance but take Medicaid as secondary. Medicaid is always the last party payer. ACHs are accountable for individuals enrolled in Medicaid who reside in their region. So that's how the attribution occurs. It won't be individuals who reside in another region and come into our region for care. Medicaid beneficiaries have to have an address within the ACH region. And they have to be enrolled in state Medicaid for 11 of 12 months during the measurement periods. Now that said, there's exceptions to all of the above. For example, emergency department utilization the individuals have to be residing in the state and under Medicaid for only 7 of the 12 months. but for the most part, this is the eligibility criteria. And let's go on to the next slide. And please stop me if anybody has questions. So we are going to compare a baseline year against a performance year, which we'll talk about in a few minutes. The baseline year is 2017, a client count as of November as of that year. And this is what the numbers look like as of that particular month and time. So about 227,331 Medicaid clients makes up the baseline year. If we can go to the next slide. So I can't point to this very well, but let me see if I can walk through this. So in that top row, you'll see those 6-sided boxes. That relates to the baseline. So in the upper left, you see where it says DY3 P4 baseline. That is the baseline year for 2017. Compared to that, on the next row, you'll see a solid blue box. That's the performance year, which is 2019. So measurements are taken in those 2 years. In that third row, you'll see a hollow blue star. That indicates where the measurement is completed for the baseline year. It takes about 6 months of claims run out to aggregate the data. Healthcare authority has to process that information. And then below that, you'll see a triangle. With that information, they apply improvement targets that we'll see in a minute. In that fourth line, you'll see solid stars. A solid star represents, that blue star represents the performance year measurement, which was 2019, but it is assessed in 2020. And then after the performance year is measured and the improvement targets are assessed, that information comes out to the ACHs. Following that, it's reviewed by the independent assessor. They score it. They apply what are called achievement values, which we'll also look at. And the achievement values tie into pay-for-performance incentives. You know, that's quite a bit of detail. The measurement guide actually goes into more details to help explain that. Let's go on to the next slide. So this is something that we've reviewed before at the PTW, and I just want to touch upon it again. There's 2 ways that performance is measured. In that middle graph, you'll see a blue circle that talks about baseline performance. That's the baseline measured in 2017. The absolute benchmark, which I think you can see there to the right of that, which says 69.4. This is a hypothetical example. For some of the measures, there are national benchmarks that come primarily from NCQA. And from NCQA, what Healthcare Authority looks at is the 90th percentile for Medicaid performance. So that makes up the absolute benchmark. That's not necessarily our improvement target. Our improvement target is 10% of the way between our baseline performance, which hypothetically here is 50%, and the absolute benchmark, which is 69.4%. So if we go 10% of the way between the baseline and the absolute benchmark, that is the improvement target, which in this example is 51.9%. Each year after there's measurement, the baseline resets and the improvement targets reset. And let's go on to the next slide. This is the other measurement methodology that's called improvement over self, or IOS. For those measures that don't have a national standard or benchmark, what HCA does is simply take the current baseline performance and looks for a 1.9% improvement. So in that bottom right graph, in this hypothetical example, you can see the baseline is 73%. Adding 1.9%, the improvement target is 74.4%. Now, if the HCA, ACH scores above that improvement target, that's 100% achievement of the pay-for-performance metric, and with that, we are assigned what's called a achievement value of 1. Let's go on to the next slide. So in this slide, this was a bit of a source of controversy. Healthcare Authority does not apply the percentage improvement to assign the achievement value or the AV. What they do is they map it to this grid above, so that, let's say in the previous example, we scored 74.4%, which is just below that 75% horizontal line. We would not get 74.4% or even 75%. It would scale down to the very next break, which is 50%. So if it scores in any of these boxes, it goes down to the break just below where that performance measure scores. So again, if it scores 58%, we would be awarded 50% an actuarial an achievement value of 0.5. If it's above 100%, it can go no higher than an achievement value of 1.0. Now, with the P4P incentives that go unearned, so let's assume that some of the ACHs, and many will, not score 100% or achievement values of 1.0, the unearned funds will go into the high performance pool, which again we'll talk about here in just a minute. Before I go on to the next slide, I just want to say that the metrics, there are 3 different types of metrics. There are metrics that have no submetrics. Diabetes care is an example. So kidney checks for diabetes is a single metric. So it would score using this methodology. Some of the other measures, such as antidepressant medication management, have 2 submetrics, one for the acute phase and one for the continuation phase. For that particular metric, because there are 2 submetrics, those 2 submetrics are averaged. And the average score is then mapped to this AV map here. A little more complicated, we can go on to the next slide, relates to metrics that actually have, can you go back, Chelsea? So a little more complicated are those metrics that have submetrics that relate to age groups. So in this hypothetical example for substance use disease treatment penetration, there are 3 age bands. The first one is 12 to 17 years, the next one is 18 to 65 years, and the third one is 65 years and older. You can see that pie chart on the right. That middle band corresponds to that green slice of the pie, which is 78%. So what happens here is that a weighted average is taken. So 78% is multiplied by the improvement, which is 75% for that submetric for 18 to 65 years of age. Same thing for the 12 to 17 years of age. In this hypothetical example, the score was 85.7, but there's 20% of Medicaid beneficiaries in that age group, so the 85.7 is multiplied by 20% to get 0.17. Once those weights are calculated, they're added together. In this example, the weighted average is 0.78. You can see where it falls on the AV map, and therefore the achievement value is 0.75. Again, I know this is a little confusing, but we're going to talk about our scoring here in just a minute, so it's important that you at least have some understanding about how that scoring works. And before I go on, I want to see, does anybody have any questions? Okay. Chelsea, for this next one, I'm going to go to the Excel document, and I'm going to try to share my screen.
Did you want to take the screen, or do I need to hand it over?
You may need to, let me see if I can do this myself.
I do have it up as well.
Okay, well, I've modified the table just a bit.
Oh. We see it.
Actually, do you guys see the table now?
Yes.
Okay, so Healthcare Authority released to the Greater Columbia some information.
It's really, really, really tiny. I don't know if you can make it any bigger. You can hardly read it. Yeah, that's better.
Is that
Thank
better?
you.
Okay. Sorry, I have a very big high-resolution monitor at my house. So here are the measures, the pay-for-performance measures that were held accountable for this cycle: all-cause ED, antidepressant medication management, children's access to primary care, 2 diabetes measures, medication management for people with asthma, mental health treatment penetration, people prescribed both opioids and sedatives, patients prescribed high-dose opioids, percent homeless, readmissions, and substance use disorder treatment penetration. Now, I've covered up the sub-metrics here, which I don't need to do because we need to go into the scores, but I just want to show you that some of these measures, again, children's and adolescents' access to primary care has the sub-metrics that are divided by those age groups. And so this is a weighted average. Antidepressant medication management is simply an arithmetic average. These measures for these 3 measures, or the calculations for these 3 measures, are just straight measures, and on and on and on. So our baseline performance, and actually you should have this table. I think Chelsea sent this table in your packet. You can see here for the 2017 baseline results for all-cause emergency department visits. Those are the metrics based on the age category, 0 to 17, 18 to 64, and 64 plus. And actually, the goal here is to reduce this. And let me see if I can freeze it here. That might make it easier. You can see what the statewide performance is relative to the ACH. Consistently, this is one of the measures that we've just been so far above the state by 30% or even more. For 0 to 17 years of age, the improvement target was to bring that down from 5303 to 5202. This was the 2017. The actual 2019 year results were 50.71. So we actually exceeded that target. So the percent improvement between 53.03 and 50.71 is a change of 238, basically 231%. Now the goal here is to go down, so actually it's a decrease, but because we want to decrease that measure, we calculate that as being an improvement of 231%. We have to adjust that because this is the absolute value, or the achievement AB calculation. It can be no higher than 100%. So this 231% scores at 100%. It goes through a weighted average for those 3 age groups. And because 89.3, remember when we looked at that AD map, that's between 75 and 100, we go down to 75%. So this is the achievement value for that particular measure overall. It's 75%, which is actually, it's not 75%, it's actually 0.75. Again, I know that's a lot of math to take into consideration. Because this particular measure covers all 4 of our project areas, we will be accounting for this measure 4 times. So in general, we did really well with emergency department visits, I think. Antidepressant medication management is another area where we scored really well. We actually showed improvement that was well above 100%. These 2 results were averaged, which gave us a total adjusted contribution of 100%. And actually, the AV here should be 1.0. Child and adolescent access to primary care. We did really well for children 2 years to 6 years, 7 to 11 years, and 12 to 19 years. However, for 2019, there was a considerable drop for children 1 to 2 years of age. In fact, it dropped by 1,078%, which gives us an adjusted improvement of 0. We can't go below 0 for the AV. This is another weighted one, but because of the good work we did with the other age groups, the total adjusted contribution is 93.5%, and the AV is actually 0.75.
Wes, can
Yes,
you
sir.
how can something decrease by 1,000%?
It went
If it was 100% before and it decreased by 1,000%, it's at minus 900%.
So what it relates to, Kevin, is this is a little confusing. It's actually
1,000% of the goal.
Yeah, it's the performance minus the baseline divided by the improvement target divided by the baseline.
So we actually did really well on the measure, but because it was small gap or small increment to goal.
Yeah, that's a very good point. That's a very good point.
Regression to the mean killed us.
Yeah, I mean, that's an excellent point, because we're scoring so high to this, even small changes can have a profound effect on this measure. And this model doesn't take that into consideration, but you're exactly right.
Okay, that I won't say that makes sense, but that explains it.
Great question. So for diabetes care, this is one where we scored below average. For both of those measures, it scored a negative, which gave us 0% improvement. These are single measures, so there's no averaging, weighted or otherwise. So we scored 0 and therefore had 0 achievement values. Medicaid management for people with asthma, we actually did very well here. We scored in excess of 331%, which is adjusted to 100. This is a single measure. Therefore, the overall contribution is 100. And again, I'm sorry, this should be an achievement value of 1.0. Mental health treatment penetration for 6 to 17 and 18 to 64 years of age, we did relatively well, not 100%. For those individuals who are 65 years and older, we actually went in the reverse direction, but this was a really small group. Only 0.1% in terms of the total Medicaid beneficiaries within that age grouping were there, so that didn't affect the average too much. So the overall contribution is 83%, and the achievement value was 0.75. For patients prescribed chronic concurrent opioids and sedative prescriptions, which is a risky thing, we actually did very well here. So it's 100, 100, and achievement value of 1.0. Patients prescribed high-dose opioid therapy, greater than 50 milligrams morphine equivalent dose and greater than 90 milligrams morphine equivalent dose, did very well there. 100%, those are averaged, so we have an achievement value of 1.0. Homeless. This is an area where, which is more of an indirect measure than a direct measure of our work. Both of these saw worsening. So unfortunately, we scored 0 on these two. And this is a weighted average, but this group had no individuals in it. So there were no earned achievement values for trying to improve homelessness for Medicaid beneficiaries. Plan all-cause readmission. This is another one that went in the wrong direction. Therefore, there was 0% positive improvement and 0 earned achievement values. Finally, substance use disorder treatment penetration. This is a broad measure that includes different categories of substance use disorder, not just opioid use disorder. Next year, there will be an additional measure that comes on that focuses on just opioids in addition to this broad measure. Here, we saw improvement for adults and those over 65, but kids 12 to 17 saw a marked worsening. So using the weighted average with these percentages within the groups, the vast majority of individuals are in the 18 to 64 years of age, 92%. That weighed heavily on the weighting, and therefore we received an achievement value of 0.75. Just as a bit of a note, so when we received these scores, everything here that's in peach, we calculated on our own. We have some files from the Healthier Washington database. They're what are called Category 1. They have sensitive data in them. I was able to go back to 2017 and pull the numbers of individuals that fit into these groups. Those may not necessarily be the exact, that may not be the exact data that Healthcare Authority uses when they do their calculation, but it should be very close. I want to give that caveat. So I'm going to move to the next sheet here, and I'll increase the resolution. So we took the achievement values and then grouped them, and this is also part of the measurement guide, that's the process that's gone through. We grouped all the measures that relate to a project area. This is Project 2A, Project 2C, Project 3A, and Project 3D. So the measures are grouped under each area. These are the possible values. There's a maximum of 1 AV for each metric in each project area. And these are the ones that we actually earned based on the analysis that you just saw. So the potential here is 9. The earned from our calculations is 5. Therefore, we earned 56% of the potential achievement values. For transitional care, potential was 3. The earned was 0.75, and this is mainly because of homeless and readmissions makes up 2/3 of the total of the 3 measures. So we earned 0.75, so we only earned 25% of the total possible AVs for Project 2C transitional care. For Project 3A, it was a total of 3 that were possible to earn. We scored 2.75, which is actually pretty good for a percentage achievement value of 92%. For Project 3D, chronic disease prevention and control, there was a possible of 5 AVs. We earned 2.5. That's a percentage achievement value of 5.0. So those are the project areas. The big question is what happens to the portfolio of projects in the scoring, and the measurement guide goes dark on that. They don't provide a lot of information. So I tried to score the portfolio in 2 different ways. One was to award each project area the same weight. For project areas, each one is weighted 25%. So there's a total of 20 potential AVs, 11 were actually earned. Using that methodology of equal weighting, we have a percentage achievement for this round of pay for performance at 55%. Now, in reality, district incentives are weighted based on the prioritization that Healthcare Authority puts on a project area. Because statewide accountability was tied to integration, they weighed Project 2A very highly. They put it at 56%. This is used in other calculations that relate to payments for incentives. Transitional care gets a weighting of 23%. Opioids gets a weighting of 7%. And chronic disease prevention and control gets a weighting of 14%. So doing the same calculation, but weighting those project areas with those percentages rather than 55%, we come up with a weighted percentage achievement value of 50%. And again, I don't know which way Healthcare Authority is going to weigh this. They may actually have a third way that I'm not thinking about, but those seem the 2 likeliest. So we assessed both. So in essence, when we budgeted, and we don't have dollars here to talk about today, but when we budgeted for pay for performance for the first year, 2019, DUI 3, demonstration year 3, we were very conservative and budgeted at about 25%. According to these calculations, we'll likely double that.
Wes, when you were running through the data, I didn't see the performance metric on the 30-day readmissions.
All cause 2A, 2C. So there it is in 2C, Kevin. And there it is in 2A. It was only in those two project areas.
Right, I see what the earned AV was. I don't see on your pay for performance sheet, I didn't see what our rates were, what our goals were, and how they changed.
So the all-cause readmission, because it went in the reverse direction, there were no AVs. It scored a 0. It actually went, using that calculation that I talked to you about, it actually went negative in this calculation.
I was looking under, I was scanning looking for all and 30 and not for, or readmission and not for plan. That's what I was missing. Thank you.
Oh, okay. Sure, no worries. Thank you for asking. Thank you for paying attention to that. Does anybody have any questions about that? I'm going to skip ahead to the next piece. We'll go back to the slide deck in just a second. Before we do that, though, I want to show you that this is the high performance pool. And these are metrics that are consistent with pay for performance, but these are tied to statewide accountability. And there are some metrics here that are not part of the pay for performance set tied to our project areas. And one big example is well child visits. Another one is percent arrested. Those metrics are tied to the high performance pool, but not to Greater Columbia pay for performance. Well child visit, substance use disorder treatment penetration, plan all cause readmission, mental health treatment penetration, medication management with people for asthma, antidepressant medication management, all cause emergency departments are all part of statewide accountability. Before, when we were talking about eligibility, I mentioned that pay for performance do not include dual eligibles. Those measures do include dual eligibles for this part of the analysis. So the numbers here may be different, even though they're the same metrics. They may be different from the analysis that we just saw. All I can tell you with this, because again, the measurement guide doesn't give detailed examples of how to do scoring, all I can say is that we improved on all these measures with the exception of the 2 social determinants of health measures. Arrest actually got worse, homelessness actually got worse. But we did score some improvement. And that's all I have to say about the high performance pool measure. As we learn more about the scoring, so I'm working with Lisa Angus, who's part of Providence Core, to ask HCA to give us more information about the scoring for this. And if and when we get that detail, we may come back to this group and present some information about it. Again, for unearned project incentives from the accountable communities of health, they go into this pool, and based on the performance of these metrics, those unearned incentives are paid out to the participating accountable communities of health.
Wes,
Chelsea, can we go back? Yeah, Barb.
I have a question about, I know all the data you're talking about is 17 compared to 19, but I'm thinking about 2020. There are certain metrics that I believe would be dramatically different in 2020 because of COVID. One of those might be the well child check for the infants or you know, kids up to 14 months, I think is the measurement. As just an example, how will the state take into the whole concept about COVID into account?
So the state for their 2020 scoring is doing some modification, and Carol can talk about this. They're looking at which is better, 2020 or 2019. And by measure, they're taking whichever year had the better improvement. So you're exactly right. We would expect, because I've seen reports that, for example, immunizations of children went down 40% year over year between April of 19 and April of 20. So that measure should be affected by COVID. Substance use disorder treatment penetration, I don't think there's any doubt that that will be affected. All-cause readmissions, I know less about this. Kevin may know more based on what he's seeing in the hospital. Mental health treatment penetration, I feel confident that will be affected, as well as emergency department utilization. So many of these measures here and in the paper performance will have some effect because of the pandemic.
Thank you.
You might expect that there will be some, based on the prevalence of COVID in a community, they may see a bump in 30-day readmission because, especially early on, folks got admitted early. It was decided that we didn't need them, we needed the space, and we sent them home until they got sick. So it was almost a planned readmission.
Interesting.
Especially in areas where capacity was an issue. If you have the luxury of space, you might keep somebody for 2 weeks to monitor them, but if you're protecting capacity, you send them home with a pulse ox and a thermometer and tell them to call back when things go south.
Interesting. Chelsea, can we go back to the slide deck, please?
Yes, just a second. While I pull this Can you see my screen? No,
Yes.
but now. Okay, thanks.
Can you advance to the next screen? Actually, two screens ahead. Okay, so we saw several pay-for-performance metrics, but that is not the full set of metrics that we'll ultimately be accountable to. This following list includes pay-for-performance metrics that were inactive in 2019, but which become active next year. And these include acute hospital utilization, asthma medication ratio, comprehensive diabetes care for eye exam, retinopathy exams, follow-up after ED visits for alcohol and other drug or dependence, follow-up after ED for mental illness, follow-up after hospitalization for mental illness, statin therapy for those individuals that have cardiovascular disease, and substance use disorder treatment penetration, but this narrower definition of opioids. So again, there will be two substance use disorder treatment penetration metrics, a broad metric and a narrow metric. Those will be added next year. So if you want to go on to the next slide, we kind of touched upon this with the high performance incentives. Incentives may be available for ACH based on total incentives unearned, do value-based, and project incentives. So those two pools will come under the high performance incentives that are unearned. Let's go to the next slide. As I talked about, these are the metrics that we just looked at. Those with asterisks are ones that will be dual eligible. Actually, yeah, homeless and percent arrested will be dual eligible too. I was thinking that those weren't. It looks like antidepressant medication management and asthma and well child visit will not be dual eligible, will not include dual eligibles, but the other ones will. So we looked at that. So there's another, if we can go to the next slide. And I'll have Sam join in here. So there's another item on the agenda which we've sort of combined here. As you know, we're getting through third quarter collection of data, even though it's November. We've had some delays because of the pandemic and some other things that have happened here recently. So that data is still aggregating within the CSI reporting portal. But we do want to point out, and I picked this particular use case around diabetes because as you remember from those two measures that were part of the pay for performance metrics for this particular reporting cycle, diabetes didn't score very well. But there are some systems in place within the CSI dashboard, and I'll let Sam run through this because she knows this really well.
So the first one is the M2 empanelment, and the practices work towards maintaining at least 95% empanelment. I showed what I pulled up just here recently for this Q3, although that we're waiting for some of the organizations since we've extended the timeline until the 29th, actually from the 15th, and then some of the organizations needed an additional 6 days, and so that was the 6th of November, and then we had 2 organizations that requested till the 12th because of COVID. So we had 80 organizations that had reported overall so far, and most of them, the majority of them, are meeting that 95% even with the COVID efforts. So that's a big applause to all of our clinics and organizations that continue to do practice transformation throughout, even through this difficult time. Risk stratification, still seeing the exact same thing. Social determinants of health, and of course this is just a tentative of looking at, who has actually reported thus far, but social determinants of health is a big integration. It's rose to the top, and I'm happy to see that. In diabetes, even with the clinical quality metrics and the risk stratification, continues to be a huge part of the overall stratification and really focusing on improvement, as well as depression screening and comprehensive diabetes care. They still continue to be at the very top of the level. So that's nice that we see that within our clinics, and our quality improvement metrics are focused on that. So again, thank you for the practice transformation clinics and organizations for continuing just to be a huge, huge implementation plan into making sure that we're meeting these metrics. Okay, Wes, you need to add anything?
I don't think so. We're getting better at analyzing the information that gets loaded into the reporting portal. In the future, we hope to come back with more detailed information about the systems and processes that we have in place, and the systems and processes that our practice transformation organizations are using to carry out their work.
In addition to comparing those PCMHAs, the different assessments that we use in order to look at previous transformation efforts into what it looks like now for these particular clinics, as well as also looking at how different practices that are grouped for like practices, for example, primary care, how they cohort 1 might look compared to cohort 1 behavioral health, cohort 2 behavioral health, or primary care that's in cohort 3, how that looks compared to the exact same time frame of cohort 1.
So this is Carol. I was wondering whether or not, Wes, we had discussed this yesterday, whether or not we are going to ask the practice transformation work group about, how to bring up some of these measures where we're, especially the clinical quality measures, where we're below our goals. For example, diabetes care. I know it's being targeted right now. Is there any conversation about whether or not we should bump up some of those incentives? Is everybody comfortable that we're going to be able to meet those metrics? Because the more we meet our metrics, the more money our providers earn. So just questioning, I guess, the providers, what do you guys think about whether or not we should, because the contracts haven't been started yet for year 3, whether or not we should look at incenting more of the measures that we're falling behind in.
Thanks, Carol.
No, this is Rhonda. I'm not sure I have an opinion about that. I think we've seen some of these numbers before, but it actually just blows me away because there are specifically about diabetes, because we have so many initiatives collectively, I say that, around diabetes. And I just, that one just really gets me in terms of, I mean, it is a very personal disease. And so in terms of finding the right motivation to help that really affects our patients, that's just a struggle. I'm just surprised because we have so much work. There's so much work going into diabetes. That one just surprises me. I don't know that money's going to be the motivator there.
Carol, this is Barb. I sort of agree with Rhonda. I think what we have to do before we figure out the solution is figure out what's the problem. Like, why are we having problems with, the measurements around diabetes? I know, like, Lourdes is really small, and I know we're doing very well with the diabetes screenings and interventions, but where are we really having the problems, and why are those problems occurring? I think we have to figure that out first and then say, oh, okay, so here are some solutions. And maybe money is the answer, but rather than putting money up front, I think we should figure out what the problem is first.
Yeah, that's a really good point, Barb, because there's some of those measures like homelessness, that they're holding us accountable to, but so you can't snap your fingers and get permanent supportive housing in a day, and then even if you do get permanent supportive housing, sometimes it takes a while to populate that housing, but in the percent arrested. So I'm assuming that there are a lot of people that are homeless that do have diabetes and other health issues, but boy, that's just really a tough nut to crack, and I feel sorry for all of the state, because this is just such a hard measure to improve.
Well, I can't imagine. This is Rhonda. Sorry, I was going to ask if we knew. Just knowing what I know about the homelessness in the state, I would be surprised if any of the regions are meeting that. If you give us housing, we'll fill the housing.
I was going to say
that's a very issue.
To your point, Rhonda, I was just going to say that the only evidence-based intervention I know of to address homelessness is to build homes.
And have supportive services around them to help people stay in there. But the diabetes measure that just gets me, and I think just putting money up front is not going to be the solution. We have a lot of interventions and lots of programs, but there's something more we need to be doing that we're not doing.
And I want to add that the Medicaid population and the statistics around that are really associated more to the patient's zip code. And what I found when I'm looking and analyzing this data is a lot of these patients go elsewhere across the state to get their primary care efforts if they're already established. And so a lot of times they don't want to travel that far for diabetes if they've got medication that's going to last them 6 months when they're prescribing that. So that's what I'm seeing across the board as well. So they're not getting their A1Cs on time, and they're not doing a lot of things, especially when they're already complacent with having medications, right? So I think that we also have to analyze the data and how it's really particularly to that region.
Is there a way within our region to identify the populations, I guess this is an odd way to say this, like populations, whether it's by age or ethnicity, that are doing really well with this measures, so that we can see if somebody's doing something differently than we are? Who are the who's serving the same population and getting better results than we are? Do we know that?
I was thinking just the exact same thing, Rhonda. I don't know that any of the ACHs have had this level of analysis for pay for performance. We're really lucky that Wes has that capacity to do that for us. But I was thinking the same thing. It would be great to start sharing this information. So if we find, for example, North Central, you know, if they're knocking this one out of the ballpark, we could say, what the heck are you guys doing? You know, especially if it's an improvement. A baseline, if they're already not having an issue, then I'm not as interested. But if they are actually improving, I want to know what are they doing to improve that. So we can have that
speaking
discussion
of which,
when we have all of the ACHs on board with their P for P measures.
Carol, I'm sorry to interrupt you. That said, actually, I can share with you something that just got released today. And Chelsea, I'm going to try to see if I can share this. Hang on just a second. Can you guys see this table?
Yes.
Can you make it a little bit bigger?
Yeah, sorry. I know this is a PDF. I have less control over this, but
See and
Carol,
read.
you are right on. Is it still too small?
Yeah.
Yeah, unfortunately, I don't know if let me see if I can get it a little bit bigger. So we just looked at the 2019 improvement targets. These are the 2021 targets. These came out just this morning. And what they're using here is 2019 data, which we saw as the performance year is now the baseline year. So we can compare, I think Carol was saying, were you saying North Central, Carol?
I just
So
threw it out there.
Sure. Great observation. We don't have it to the level of detail that Rhonda just described, although in a future release of Healthier Washington dashboard data, we might be able to get that. But if we look at diabetes, which is right here, I'll try to mark that row. We can see Greater Columbia. So the order is eye, blood, kidney. So our top one is 46.86 per eye. We're actually the second highest in the state. So in terms of screening for retinopathy, we do really, really well. The second one is blood. We're at 83.57. We are a little lower on that. There are several regions, including North Central, who does quite a bit above that at 89.08. And for kidney, we score 82.94. And for that one as well, this is something that Carol pointed out earlier in another look at data. We are quite a bit lower in that one. So we do well in eye screening. We're sort of middle of the pack, needing to improve in blood sugar screening, and in kidney screening, we have a long ways to go. So this is information I can forward out to the group so you can compare what the baseline measures are for the other ACHs. Does anybody else have any other observations or questions, comments about everything that we've talked about? Of course, you know, that's a lot of data and analysis to consume all at once.
Wes, is this a table you could share with us?
Yes, I'll send this to Chelsea and I'll ask her to forward it out to the PTW.
Thank you.
Chelsea, it's all yours.
So Mark had to step away, and so I'm going to go ahead and intervene. On the agenda, I'm up next, but we've already went over the dashboard in that last slide that Wes presented. for the empanelment risk stratification clinical quality metrics. So I'd like to share something with you just during this time that we have associated for or set out for this particular subject. So I have 2 practice navigators that have been out on maternity leave, and then one that has been out ill. So please bear with us to be patient with us working through this time. But I would like to share their pictures, their baby pictures. So if you could pull that up for me, Chelsea.
Drum roll, please.
So we have little Camilla, which is Martine's on the left, and then we have little Zoe on the right, which is Brittany's new baby.
I got
Well,
to
they
rock.
better get their well child visits. Oh, sorry, Everett.
Sleep last week. That was very nice for me because I haven't gotten to do that for a while. So.
Oh, okay.
Hey, we can go ahead and continue, Chelsea, with the next item. I'm going over the next meeting schedule. If you can pull that up for me, please. So our quarterly meetings will convene from 1 to 3 p.m. The next one will be March 4th for 2021, June 3rd for the next quarterly, as well as September 3rd and December 2nd for 2021. Are there any questions on that?
Yeah, Sam, that seems counter to the reporting.
It does. You're exactly right.
I think we're gonna have to revisit these because those quarterly reports aren't even due until the end of the quarter, and March is part of the first quarter. So.
And then the other thing I wanted to add to that for the quarterly reporting is if your QI efforts are more in line with the time that the actual reporting is occurring, if you can actually make it more at the first of the month so that we can get them in more timely fashion, that would be, if you're using your QI team to do the reporting, to make it sooner than later, I'd appreciate that. And then we can actually get some monies out a lot quicker as well. But yeah, we'll definitely revisit these and look at what is best for being able to present the reportings for those different quarters so that we'll have that available. And at this time, do we have anything else, any comments, anything that we need to discuss? So we're done pretty early.
So I want to circle back to the discussion about contracts and next year. So next year would be our 3rd and final year practice transformation paying our providers for performance. We asked Rhonda at one other meeting whether or not, scaling down the program to be half as much as what it was this year would still be worthwhile, and she said yes. So I just want to make sure that everybody understands that as we progress, we're hoping that it gets a little bit easier to do and accomplish some of these milestones that are in the toolkit. But that is the plan, is that we will continue this program through year 3 for all of the cohorts. That's what's in our cash flow, but it does scale down in terms of funding. But I guess some money is better than no money, right, Rhonda?
Absolutely. The only program that's paying us to do this, so it works for me.
My brother used to say there are 2 main rules of finance. It's better to pay later than sooner, and it's better to get more than less. And those are basically his 2 rules of finance. So it's carried me a long way.
Any other comments on that?
Thanks for all the data, Wes.
Yeah, definitely.
My pleasure. please feel free to follow up with me with emails or call me if you have any questions about any of that.
Thanks, everybody.
Thank you. Bye.
Hey, we'll
Bye.
give you
Thanks, guys.
45 minutes back. Thanks. Bye-bye.
Bye-bye.
Bye,
Bye.
everybody.